Hi, this is Brian Kim. I want to share with you this case of a patient who suddenly jerked his head away from me while I was doing the Rhexis and I get a run out. And so I'm going to show you one, cataract surgery is surgery. Bad things can happen, and you have to know how to adjust, pivot, refocus, and figure out and assess what to do next and basically troubleshoot the situation. And so you're going to be able to see this fairly routine cataract turn into not quite a routine cataract situation, and then how I'm able to kind of circle back and around and make this a routine situation once again. So I'm using a cotton tip to steady the eye and straighten the eye, and this is a corneal marker which helps me to center and size a Rhexis. And you can see the patient has a little bit of a Bell's reflex. This is the left eye. I'm turning the eye down towards the left. I'm making my paracentesis incision, which is flat to the iris plane. This creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. I'm doing the same thing now on the left side. Of course, this patient's left eye wants to look to the left, which is upward, which is easy to make that incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then this is some dispersive viscoelastic to fill the anterior chamber, flatten the anterior capsule, and also to coat the corneal endothelium. You can see I'm doing the Orlock technique because this patient does have a little bit of a Bell's reflex, which means I'm twisting the cannula to hold the eye steady. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. And so I'm using, again, the cannula as the Orlock. I'm able to turn the eye downward and keeping it straight. These are the sharp tip capsule Rhexis forceps. I puncture, and then I'm grabbing. And as I'm grabbing, look what happens. So, so I'm going to just show you that in slow motion. The patient suddenly moves away. I let go of my grip, but I think the patient got the best of me. And as you can see here, there's a little bit of a run out here. And so whenever these things happen, you have to just pause, compose yourself, reevaluate, and of course, engage the patient, make sure they're awake, make sure they're oriented, make sure they're not trying to get off the table, figure out what happened. It turned out the patient just fell asleep and he just suddenly moved. And so this patient, for some reason, when he dozes off, when he wakes back up, he just suddenly wants to get up. And so we learned that. And of course, for the second eye, I believe we probably would block his second eye because we're trying to anticipate and prevent any future problems. And so that's the other thing. Whenever you're dealing with a surgery like this, you don't want to repeat the same situation because the definition of insanity is doing the same thing and expecting something different to happen. And so most likely we'll block his other eye, his right eye, when we do that case. And so now I'm going to evaluate. I'll push some viscoelastic in. And again, this patient wants to look up, push some more viscoelastic, and then using the Orlock to see if there's anything I can do with the Rhexis. And so I'm very carefully grabbing it, and I'm able to turn it the other direction. So thankfully, it didn't go all the way across. It's very, very far up, and the patient moved once again in the middle of the Rhexis going the other way. So I'm really trying to engage the patient, try to not have him fall asleep. And I'm talking in a really loud voice right now, trying to keep him awake because he keeps falling asleep. And every time he falls asleep, I cannot trust that he's going to be still. And so I'm holding the eye with the Orlock. I'm going now clockwise, which is not my normal capsule Rhexis pattern. I like to go counterclockwise. But again, you have to pivot and adapt in these cases. I'm able to hold the eye again. He does have that Bell's. I'm trying to hold the eye the best I can. I'm trying to get a good size of the Rhexis without it radializing. I'm talking to the patient the entire time, making sure he doesn't jerk away from me for a third time. And then luckily, I'm able to finish off the Rhexis. And so now let's evaluate and see what's going on. We're going to now do the capsular fornix hydrodissection technique. I place the cannula under the Rhexis edge, contra incisionally, point the tip down, get a nice wave, decompress on the left side, and then I'm hooking the peripheral lens and it begins to spin on the right side. And you can see every time I push fluid in, the patient reacts. You can see that. See, he's got that immediate squeeze. And so, again, this is a fairly common characteristic of these patients, strong Bell's reflex, kind of squeezing every time you put water on the eye. He's just overstimulated. And, we try to put him to sleep. And then, obviously he wakes up in the middle. And so it's just a bad situation. So I think a block is really the best option for a patient like this. So you saw I did the double chop technique, placing the chopper around the Rhexis edge and pointing the phaco tip vertically subincisionally, and then basically fracturing the lens in half, and then placing the chopper around the right heminucleus, fracturing the right heminucleus in half, and that is the cross chop maneuver. I've removed that first quadrant, and now I'm lifting that second quadrant, crushing it in half, and then emulsifying the lens piece as well. And so I'm going fairly slowly here. I'm just fracturing the lens pieces into smaller pieces. I'm able to carefully rotate the second heminucleus in front of me, fracturing the lens, and then getting around that third quadrant, crushing that piece in half. And you can see I'm able to use mechanical fracturing forces to very carefully and systematically disassemble the lens into smaller pieces and then emulsify the lens pieces. And this is the fourth quadrant, getting the chopper around the lens piece, hooking it up, crushing the lens piece into smaller pieces, and then emulsifying the lens pieces. By doing it this way, using minimal ultrasonic energy and fracturing the lens pieces into smaller pieces, I feel like I have exquisite control. I'm able to keep the CDE down. And again, postoperatively, I do tend to have clearer corneas post-op day one. And so I do feel like this translates to safer surgery, less endothelial damage, and happier patients. So I take the chopper out, push BSS in, take the phaco tip out, and then I go in with the INA handpiece. I start subincisionally. Obviously, subincisionally, the Rhexis is quite wider in that area. And once we clean up the cortex, we'll have a better idea of how we are. Again, I don't feel like there's any forces that are directed to the subincisional area. And so even if the Rhexis is incomplete in the subincisional area, I do still feel fairly confident that I would at least be able to place the lens into the sulcus, or I'll be able to place the lens into the capsular bag, a single piece lens into the capsular bag with the haptics oriented 90 degrees from the subincisional area. You can see I'm using the polish mode to polish underneath the Rhexis edge. It looks really nice and clean there, polishing the posterior capsule as well. And that polymer's tip is really, really excellent, very safe, and I feel very confident as I'm polishing the capsular bag with it. So I'm pulsing the subincisional space with the BSS cannula. Pulsing the BSS into the subincisional capsular fornix helps to pulse and remove any remnants of cortical material. Fill the bag with cohesive viscoelastic, and then I'm polishing with the sweep on either side. This is a single piece of acrylic lens. It's going to go into the capsular bag. And the nice thing about single piece acrylic lenses, of course, is they unfold really slowly. And in these situations in particular, it's quite advantageous because you're able to position the lens while it's still in a taco form within the capsular bag. Again, rotating it like I did, 90 degrees clockwise, tilting it, getting underneath the lens, ensuring there's no viscoelastic trapped underneath the lens, as well as making sure both haptics are within the bag. I'm turning the haptics to make sure here that they are 90 degrees. And you can see you can rotate the lens counterclockwise as long as the bag is fully inflated. And you saw I used the tip to just nudge it counterclockwise there. I'm polishing underneath the Rhexis edge here. And so, I really averted quite a disaster with this patient. He, again, jerking movements, unreliable during the most critical aspect of the case. During the Rhexis, I had a near miss on the Rhexis run out, not just once, but twice. And so, clear communication with this very somnolent patient who obviously, when he gets stimulated, suddenly tries to get up. And you can see I'm just going to start hydrating my incisions at the end. I always try to keep the chamber as stable as possible, limit fluid egress, and not letting the eye collapse if I can. And thankfully, the lens is in the bag. I don't believe there's a Rhexis run out, but it's pretty far peripheral there. Like you saw the patient move again. This is the third time he's moved, and hopefully the last before we end this case. And so, these patients, you never know. I mean, you can do thousands and thousands of cases and not encounter a patient like this, and then you do, and it could just be a big challenge. If this happens once, you got to figure out a different way for the second eye because you don't want to go through this again. So I do believe we did a block for his second eye, and we're going to just try to keep him engaged and not so sleepy. Of course, patients get really anxious. Sometimes they don't sleep the night before surgery because they're so nervous. And so those people tend to be really hypersomnolent. And so there's no way around that, and there's no way to avoid that. You can see just a little bit of stimulation with the BSS. This patient's very reactive, even during the hydration of the incisions. So that should also give you some clues that this type of patient may not do so well with topical. And thankfully, at the end of the case, the patient did very well. This still was a fairly efficiently performed surgery with minimal ultrasonic energy use, and the patient ultimately did great. So I hope this was helpful to you, and I thank you for your attention.